Go ahead, Jim.
Thanks. Okay, thank you so much. Though it's truly an honor to be here and present, as Ed mentioned, it's under unfortunate circumstances. Our colleague, Dr. Seben Sanzimana, was unable to acquire his visa in time. So I just arrived back late last night from Rwanda and now presenting this morning. So bear with me as I present slides that are not mine on short notice and under little sleep. So. To acknowledge first, the Rwandan HIV Comprehensive Guidelines Technical Working Group is the group that really put all of this together. Dr. Seben Sanzimana wants me to particularly thank the co-authors of this, Sabino Alice of the Clinton Health Access Initiative, Mpundo Rubakara and Eric Romero from the Rwandan Biomedical Center where we were working, and the Honorable Minister of Health, Dr. Anya Spinaguaho, as well as he mentioned, myself and Dr. Edward Mills for accepting to present this presentation on his behalf. So I'm going to start by a little bit of background, talking about the 2013 HIV guidelines and what kind of changes they are, what the results of that are, particularly around costing, and some conclusions to wrap up. So Rwanda is a small country, as most of you know. It's one of the densest countries in Africa, about 10.5 million inhabitants, rather hilly, and the country has tripled its GDP in the last decade or so. And made some remarkable economic and health outcomes. There's the connection that our team is building. I only wish my flight was this direct. The epidemiological situation in the country, the overall prevalence is about 3%, but some notably high prevalence among particular groups, particularly female sex workers. The recent behavioral surveillance survey of 2010 showed a 51% prevalence. Pregnant women around 3.3% at sentinel sites, youth 1.6%, people of the Rwandan military 2.8%, prisoners 4.7%, and the country is just starting its first round of surveillance among men who have sex with men this year. The total number of people on ART in the country is 129,405. The orange circle on the outside represents the number of people that will potentially go on to ART who are linked to care currently, but whose CD4 is higher than 350. Then the outside green circle thus represents the total number of people, and the white area then would be people who are somehow lost to care, and we need to re-engage and move them back into the orange and blue circles. So this is ART coverage over time. The red 65.3% there is when the country introduced the new guidelines, so that's seen the drop there. Currently, the coverage is about 93.1% under the current guidelines. And the change in guidelines, which I'll talk about in a second, will reduce coverage to about 80%. So the 2013 guidelines. So the objective of this analysis then was to measure the financial costs and the health impact of expanding ART coverage through an eligibility criteria of under 500 when compared to the current guidelines, which are under 350. So the costing analysis was performed using an ingredients approach or components, units of all the relevant to HIV interventions. It was done by using a tool called One Health Tool, a WHO endorsed program to calculate the number of services required each year under the different strategies. Data came from the annual quantification reports, national annual surveys on testing, prevention, and treatment, generated by the TrackNet data, which Ed just spoke about. The limitation to this, though, is that this is just on treatment. It doesn't reflect a full comprehensive plan of the response that would include things like psychosocial support, nutritional support, etc. So the new strategy, endorsed in August and finally adopted in December of last year, and now currently on a 6-month rollout plan, involves HIV-positive patients onto treatment under 500. Also, with a 3 or 4 WHO classification stage disease, patients that are co-infected with TB and hepatitis, serodiscordant couples, pregnant women on B+, and a test and treat approach for female sex workers and for men who have sex with men. So, thus, what is some of the results given this new eligibility criteria? So the main cost is going to come from the treatment itself, increasing about $127 per person to $137. The rest will mostly stay the same, but it requires an additional investment of $12.7 million US over the next 5 years. The biggest investment is going to be in that first year, as this graph shows here. That the cost per year of the two strategies shows a significant increase there in that first year, and that the new strategy and a potential decrease in the following years. Additional analysis with an extended time frame is thus required then to confirm the decreasing trend. Two figures here show the health outcomes that are associated potentially with this new strategy. The orange area on the left figure shows a decrease in the number of AIDS deaths proposed under this strategy, and the figure on the right would show a decreasing number of 7,586 estimated new infections. Also, of course, a reduction in morbidity and mortality, reduction in additional costs to the healthcare system, which I'm going to describe in a second, and also, of course, increased productivity among positive people who are thus healthier. So what are some main areas in which the healthcare system can potentially benefit from this new guidelines approach? The treatment for opportunistic infections is greatly higher in inpatient costs than outpatient costs, of course. In fact, in OI complex care, it's $35.23 per day. And costing those 7,586 new infections averted will potentially save the health system $27.3 million over the plan. So some general conclusions here that by investing $12.7 million US in the next 5 years, the country will estimate an additional 12,800 patients with the CD4 below 500 will be put on treatment. Between 2013 and 2017, then, Rwanda would benefit from a reduction in mortality and incidence as a result of this, including an estimated 6,394 less AIDS-related deaths and potentially 7,586 new HIV infections averted. And that the number of new infections averted will potentially save the health system $27 million just on treatment and labs alone. That's not the full complex costing. So thank you very much for allowing me to present today. Thank you so much to our colleagues and our research collaboration, and I'm happy to take questions at the end. Thank you.